Good morning, everyone. I'd like to welcome you to Global Health Grand Rounds this morning. Thank you for joining us. My name is Serena Koenig, and I will be introducing our speaker today. Our speaker is Professor Nombulelo Magula, and she's going to be speaking to us about light at the end of the tunnel to attaining sustainable development goals, disrupting the hierarchy of the healthcare system. Professor Nombulelo Magula is the head of the Division of Internal Medicine and a leader of the clinical team at Clarewood Hospital in Durban, South Africa. She was born and bred in the township of KwaZulu-Natal in Durban. She completed her bachelor's in chemistry at the University of Cape Town and medicine at the Medical University of Southern Africa, followed by specialist training in internal medicine at the King Edward Hospital and the University of KwaZulu-Natal. Professor Magula was subsequently awarded the Fogarty Fellowship to study clinical research at the New England Medical Center and the Sackler School of Graduate Biomedical Sciences at Tufts. She completed her PhD at the University of KwaZulu-Natal, studying metabolic complications of antiretroviral therapy in a South African Black population, which was funded by the Discovery Foundation and the South African Medical Research Council. Professor Magula has served as a Senate representative on the University of KwaZulu-Natal Council, a member of the South African Ministerial Advisory Committee on COVID-19, and she chaired the Clinical Management Committee for COVID-19 for the province of KwaZulu-Natal. Professor Magula served as a member of the South African delegation under the International Visitor Leadership Program, which was hosted by the U.S. government and the National Institutes of Health and the Centers for Disease Control on the Global Health Security Agenda. She is a mother of 3 daughters, an avid runner, and she enjoys gardening. We welcome her, and we're very excited to hear what you have to say this morning. Thank you.
Thank you very much for that warm introduction, and thank you very much for the invitation. I'm just going to pull up my slides now. Yes, so let me just go get to. All right. Okay. So with that introduction, I will jump right into it. Thank you very much. And the outline of my talk will just cover, a number of topics, a convergence of epidemics in South Africa. And I'm trying to answer the question, is it all doom and gloom? And also go into a bit of a historical perspective and speak about where the light is from my perspective. So this convergence of epidemics in South Africa, beginning with what we see with the epidemic, the pandemic, COVID-19 pandemic, where when you look at Africa as a continent, we see that the proportion that is carried by the number of, by South Africa, which amounts to a third, more than a third, or rather, just over 30%. Of infections in the entire continent are located in South Africa. You look at deaths, same story, almost 40% of the deaths that occurred until the end of 2022 in Africa, 40% occurred in South Africa. You look at HIV infection, people living with HIV at the end of 2021, you look at South Africa carrying almost 32% of people for the entire continent, with South Africa having the largest number of people living in South Africa for the entire world. So that's from an infectious disease perspective. When we look at non-communicable diseases, you look at diabetes mellitus, and again, South Africa leading the whole entire continent with the number of people living with diabetes in 2021 as reported by the International Diabetes Federation, accounting for almost 18% of people living with diabetes in Africa. remembering that there's 54 countries in in the continent, and South Africa bearing the burden of most. Question, is it all doom and gloom? So we start with having to understand what our problem is. And this systematic review shows that even in the era of antiretroviral treatment therapy, the systematic review covering the period 2008 to 2018, showing that deaths amongst people living with HIV, #1 cause is still tuberculosis. And this slide here shows that in the past, in the decade between 2011 to 2021, South Africa shot up to become the country with the highest growth in number of people living with diabetes, from 1.9 million in 2011 to more than 4 million in 2021, becoming the #1 country in Africa with diabetes, people living with diabetes. This slide here shows the work that we're able to achieve in terms of bringing together our healthcare system in the private and the public sector, having one unified data system where we could see all the patients that are being admitted in hospitals across the country, across the private as well as the public health system, which was a big achievement because we have two parallel health systems in the country. But this is a picture of what we begin to know and what is possible within the country. Again, the same picture with a demographic background in terms of age and gender, showing patients that were admitted across all hospitals, private and public, and across the country. And this is a representation of individual provinces and data that was collected across all the provinces in the country as the pandemic unfolded. Now, what we do see in the country is that there is a disproportionate burden. We saw that with the COVID-19, we saw that before that with the HIV infection, social ills, that disproportionate burden is on women, children, and the vulnerable groups. We see a lot of gender-based violence and violence in general, substance abuse, stigma and discrimination associated with HIV infection, mental health illness, and a whole lot of other problems that are carried by women, and poverty being a central problem in all of these issues that women face. So the question is then, but why are the women of South Africa and South Africa in general being, why is it so vulnerable to epidemics? And one could look at how the HIV epidemic unfolded in the country. And this slide is a depiction of the monitoring that occurred right from the early days of the emergence of HIV infection, where women attending antenatal clinics are monitored. And you can see as far back as 1990, when the infections were just emerging, and we were not responding with treatment as a country, and treatment only becoming available in 2004, freely becoming available in the country. But depending on where you sit in terms of your socioeconomic status, you could have been able to access antiretroviral treatment but those that are reliant on the public health sector, the solutions only came in 2004. And you can see by then that the prevalence was sitting at more than 35% amongst women that were attending antenatal clinics, rising up to more than 40%. And the province that I come from is actually the hardest hit. It's the epicenter, and the district where I actually grew up is the epicenter of the HIV epidemic. So that would be one way of looking at it, that we had a delayed response. Another way that we look at it is if we look deeper into the history of South Africa. Not a lot is spoken about slavery in the time of colonialism. I think there's a lot more around slavery and the experiences of people in the regions of Western Africa, not so much that's spoken about in South Africa. But that is one of the pieces of the history of South Africa. And this colonial rule then was followed by, and this is probably unique to South Africa, this experience, where after the colonial rule and the slavery that was experienced by people of South Africa was the apartheid rule that now separated people according to their skin color. And so if you were Black, you were not allowed to live in certain areas. This law, it was actually legal, to impose, separated families, because men would then leave their homes to go and find work in cities, leaving their wives behind, only to return during the holidays. And so families were broken down. So when the HIV epidemic emerged, families, husbands and wives were living apart, with men having wives in the cities, with their wives living in their rural homes, and are returning only to infect their wives. So there's another piece of the history that has caused the HIV epidemic to be difficult to deal with in the country, because of the social fiber of society that was broken down and still remains as a legacy of the apartheid era. And so when we look back at how we got to 1994, that brought us our liberation, students were up in arms and fought. And this took us to 1994. And this generation was the first generation as Black people to have an opportunity to vote for a government of their country. Because in 1994, they actually were 18 years at the time, or rather anyone that was born in this year that was historical for the country was 18 and was able to vote. But come 2016, years later, after we were liberated, sins of 1976, we still see them. And so the question is why? And so we look at our environment, same story. We experienced flooding in the apartheid era, and now more recently we're seeing this, natural disasters that we actually were not very familiar with, that are now occurring more and more frequently. 2017 was the previous slide, 2022. These are natural disasters that as a country we were actually not familiar with. So what has now happened is, yes, we were separated by color. We're separated by whether you were Black or white, and whether you were able to live in this place, or the laws prohibited you to move in certain places, to access healthcare in certain places. You couldn't because of your skin color. But those laws are no longer in existence. But what has replaced that is a system that allows people to access resources depending on whether you have or you do not have. And so we have a parallel healthcare system for private as well as public that almost resembles what we had prior to 1994, when the country was liberated, that was distinguished by skin color. So coming to the light of the tunnel that I want to talk about is firstly understanding what our problem is. And I think we are getting there. And when we look at what the COVID-19 pandemic has taught us, one of the big things that we learned is that we got to talk about vaccination, and we got to hear what the issues are at community level about vaccination, something that we should actually have been dealing with all along, something that's common practice for children. I think our vaccination coverage for children is very high. It's around well, not 100%, but pretty good. But when it comes to adults, we actually don't talk about vaccination much. But COVID-19 actually showed us that we need to have more of these conversations around immunization. And when you look at the Sustainable Development Goals, just about 13 of the Sustainable Development Goals can be achieved just with vaccination alone. You look at elimination of poverty, nutrition, health and well-being, education attainment, gender equality, clean water. Vaccination has, or immunization has something to contribute to all of this. Clean energy, decent work and economic growth, all the way to climate change. We can actually see the role of vaccination in attaining all of these Sustainable Development Goals. And the one on health and wellness and reducing morbidity and mortality, we can focus on that. And because we saw so much of loss of young lives during the COVID-19 pandemic in particular. So we learned to implement local solutions on the go as we began to understand them. And one of the big lights was actually the coming together of experts around the country, which was made possible through the pandemic, that we could come together, the entire country experts coming up with solutions to guide government, which is something that we had actually never before experienced prior to the pandemic. It's like government does what government does and academics do what academics do. But with the pandemic, we had an opportunity as academics to inform, engage with government, and whatever solutions that were brought forward would have been deliberated, digested, and recommended by academics and experts. And we also learned more about the country, distinct risk factors. Very early on in the pandemic, we learned all the risk factors that make people vulnerable to severe disease and dying. But we found through the database that I shared with, that I mentioned, alluded to earlier, we were able to identify risk factors that were actually unique to South Africa, which was HIV infection, particularly those that were not taking antiretroviral treatment, which is a big problem that we see in our country, where even despite treatment being available, we still see a large proportion of people, falling ill and succumbing to HIV-related complications. And so this paper showed HIV infection as one of the risk factors in our population. And so some of the things that we learned on the go was the importance of training healthcare workers, as well as taking services closer to where people are, taking specialist support to closer to where the communities are, which is something that is very unusual in our context, because we have a system that is very much hierarchical, where you actually have to earn your pass to the next level of care by complicating. And COVID-19 clearly made it clear there wasn't time for this. And so this forced us to find solutions. And so we did. We found solutions, we developed strategies, we trained healthcare workers that are working close to communities, and this facility was repurposed. Physical infrastructure repurposed, and then training of healthcare workers to be able to manage patients that would otherwise, previous to this, the facility would not have been able to manage them. This is the sort of training that was happening in the early days to prepare clinicians and nurses. And so we saw problems that were presenting in our facilities that were very unique to what other people were seeing. Co-infections. This patient, for instance, presented with a combination of COVID-19 infection, pulmonary tuberculosis, confirmed at the same time, pneumocystis, cerevisiae, pneumonia, and she also developed a pulmonary embolus. And this was in the early days of the pandemic. And this young lady, who was one of our youngest, in fact, she was the youngest patient that we had admitted at the time, and she otherwise would actually have succumbed had she not been able to access specialist care immediately directly from a community health facility. When she presented with a pleural effusion, with pulmonary tuberculosis, also complicated with an iatrogenic pneumothorax, and was on non-invasive ventilation for months, and happily also complicated with pulmonary embolus. And it was a moment of celebration when this young lady left the hospital well. And we saw, from a combination of 2 to 3 or 4 infections all the way to this patient that had 7 infections, all diagnosed at the same time, showing the unique problem that we're facing of this convergence of epidemics. This patient, at the same time that she was diagnosed with COVID-19, he had underlying HIV infection. And we also, at the same time, diagnosed hepatitis B infection, hepatitis C infection, pneumocystis cerevisiae pneumonia, Klebsiella pneumonia, bronchiectasis, pulmonary embolism. And again, we were happy to see him off home. And this brings us to a point where we actually appreciated a role of contributing our experiences on the global agenda in terms of clinical research. So as a country and institutions across the country, we contributed and worked hand in glove with all the centers that participated in the Solidarity trial that was led by the World Health Organization. So for us to contribute our, to have our patients participate in this global clinical trial was something that was a big positive, because of understanding that we have a very unique, profile of disease that we manage. And this slide shows all the academic institutions across the country that participated in the Solidarity clinical trial. We also had an opportunity to work with the National Department of Health on clinical management with oxygen therapy, together with other global institutions and other institutions in the country. And fast forward, we also participated following the Solidarity trial as academic institutions. We also participated in the recovery clinical trial that most colleagues will know has been the largest global clinical trial. And for us, it was also quite beneficial to be able to contribute participants to this clinical trial that is ongoing. Now, fast forward 2023. By the end of 2022, the recovery trial had actually tested many drugs, both the Solidarity, the recovery, and many other clinical trials had produced data that firmed up decisions on whether this works, that doesn't work, and so on. So having participated in all of those global trials and contributed our participants, come 2023, we still see a very unique disease profile in our country that, to a large extent, most of the work that we have done at a global level still doesn't answer our problem. For instance, this young woman who's 38 years old, who's been living with HIV from 2007 on treatment, on and off, and by 2022 November, she'd had 2 other episodes of pulmonary tuberculosis when she was diagnosed again with tuberculosis. And between November and February, she'd had an episode of defaulting her treatment and presented to us. And now with COVID-19 pneumonia and still gene expert positive for pulmonary tuberculosis, and treated her from non-invasive ventilation, or rather from high flow nasal oxygen all the way to non-invasive ventilation. And a lesson here for us is that, yes, we've participated in global clinical trials. One of the drugs that is readily available now in managing patients in hospital with severe COVID-19 pneumonia is baricitinib, and it is actually approved in our clinical guidelines. But our biggest problem in the country is pulmonary tuberculosis, which you can't use in the context of we can't use baricitinib. So this particular patient, we actually have a drug that is available that our government pays for treating somebody that's hospitalized with COVID-19, but because she has pulmonary tuberculosis, we can't use. You look at, I'm forgetting this other drug now that it'll come back to my mind just now, that we also can't use in the context of using rifampicin. And yeah, so this is all data that's coming out to say, in a patient that is at risk, that you know is at risk of developing severe COVID-19, this is what you do, but we can't use those strategies in the context of pulmonary tuberculosis. Then we have these 2 patients also now in 2023, when there's a sense of relaxation, a sense like, oh, COVID-19 is now behind us. These 2 patients, both of them, well, a male and a female, age 55 and 68, both of them HIV negative. The risk factor for the woman is obesity, and the man is type 2 diabetes mellitus, and he's had cardiovascular disease, having had stents put in, and hypertension for 10 years. So those are his risk factors for severe disease. Come to vaccination. They only had 1 dose of vaccination and no boosters. Never had a COVID-19 infection. So they came into us severely ill, both of them. We managed them with high flow all the way to non-invasive ventilation. They both ended up requiring invasive ventilation in ICU, and both of them died. So this is now in 2023, when we believe that there is so much now that we know that we didn't know before, but we have knowledge about vaccination now coming in the way for these 2 people that had never seen COVID-19 naturally, but did not vaccinate properly, living with non-communicable diseases and succumbing to COVID-19. Now, this slide here, which actually is a meta-analysis of studies that looked at thrombolytic therapy. in people with prevention of death using thrombolytic therapy in people with myocardial infarction. And what we take out of this is that it took, you know, there was evidence from the early 70s, but studies, clinical trials continued all the way until 1990, when data was already clearly there to show benefit from thrombolytic therapy in people with myocardial infarction. The reason I'm showing this slide is that for the problems that I have alluded to that we experience in South Africa, clearly we need more than medical therapy in terms, we need more than medicines, because the clinical trials, yes, we can do clinical trials and we can put people on medication, but the management of tuberculosis dictates solutions that go far beyond medication, whether it is for HIV infection or whether it is for tuberculosis. Interventions that are required are something that go far beyond medication, and education for those that don't even have HIV, and education about vaccination. So now coming closer to the brighter light. So at the end of this tunnel that I'm referring to are the young people that are taking on the baton and running with it. We have this young man who's actually looking at the impact of technology on access to healthcare for patients, that abolishes a hierarchical approach in the current referral network, which dictates specialist intervention can only be sought after disease progression has peaked. And so he's doing this for his master's degree, taking lessons from what we learned during the COVID-19 pandemic. And this young lady here is developing an integrated approach, screening approach. She's evaluating the effectiveness of an integrated screening approach and developing a tool for integrated screening from lessons learned. A primary healthcare integrated approach is going to be reviewing policies on screening for communicable and non-communicable diseases, and whether there is screening that is done in an integrated manner. And this is also for her master's project. And this young man is looking at implementing such an integrated tool, looking at cardiovascular risk profile among teenagers and adults, using a screening tool for integrated health promotion, disease prevention, and management at Clarewood Hospital, which is going to be his pilot project for a master's degree. And all their projects have been funded by, or are being funded by one of our private sector, rather medical aid schemes. So this picture, as I move towards close, is a depiction of, if you look at the middle blue boxes, that is the structure of our healthcare system, starting from the clinic, going to a community health center, district, as well as a regional and then quaternary facility where you ultimately end up in. And that is how our health system is structured for the public sector. So if you access the public sector, this is what you have to go through. You can't see a doctor from your home, but that is different if you are in the private health system. You can see a doctor, you can see a specialist. It just depends on what your resources are. So what we're doing now, and we've been working with our provincial and national government, is if you look at the orange box and the circle below that, which is a household and people living in the household, and we're looking at how we bring services to people within their household, so that we're working with community health workers that can visit and understand the family, the issues, the needs, the health problems, you name it, and bring them together with the different sectors of government be it agriculture, human settlement, all sectors of government, basic education, and so on, all in the spirit of promoting health and preventing disease, control, and also bringing about early management and early introduction into the health system. And the community health workers work through a ward-based outreach team led by a leader that connects the community health workers with a clinic. So for me, I see this as really what is going to bring together and close the gap between the haves and the have-nots that have come up because of this separation in the state of our economy and how people access it. This is a picture that is actually the work of what I have just shown you in progress. I'm sure you might recognize some of the colleagues in the picture doing implementation science work, which is just if I go back to that slide with the thrombolytic therapy clinical trials to show what we need. This is the type of work that we need that goes beyond just testing drugs. And months later, this team that I've just shown you, the work that is underway with community health workers, the people there that are not in the previous slide, in blue, are the community health workers and the nurses that are working with households, screening and managing hypertension. I'm not going to go into the trial, but just to give a sense of the work that is happening at community level, which is really a solution that South Africa requires. And the brightest light, and this last picture I'm going to show you, is what inspired my title today to say that there is a light at the end of the tunnel. And this is the picture where we actually take work. You know, you have people coming all the way from Boston, Massachusetts to come and visit this woman in her homestead and have her blood pressure taken and have her educated about managing her blood pressure. So for me, this is the biggest light, and we just need more of this. And yeah, so I'm just going to close with these two quotes. One is that if it's true that a chain is only as strong as its weakest link, isn't it also true a society is only as healthy as its sickest citizen and only as wealthy as its most deprived? And this last one here, you teach what you know, but you reproduce what you are. And with that, I thank you for your attention.
Thank you so much. That was really wonderful, very thought-provoking and very interesting. I'd love the audience to pose any questions that they might have. You can use the Q&A feature if you'd like, and we're happy to ask them of you. Maybe I can get started with a question for you, and your vision of the community health worker approach and engaging in communities is very inspiring. And also, I know there's been a lot of work in South Africa around community health workers and their role and function. And it would be interesting to hear from you what you think are the biggest maybe challenges, but also opportunities in terms of national policy around this, or where that stands, or how are the health authorities really taking on the notion of community health workers and their role formally in the system beyond individual projects and pilots.
Yeah, thank you. Thank you so much for that question. And so our health system does recognize the role that community health workers can play. There is a certain so the different provinces have different levels of maturity in incorporating community health workers. And I think our province, my province, I think probably has a lot more established community health worker system. There is a background to it, is in that it was actually, it's an idea that was actually born from a political space, where there's a system called Operation Sukuma Sake, Operation Get Up and Build. And part of that operation, where you bring the different sectors of government together, and each of the districts of the province, there's a political leader that actually leads this agenda. But that is something that is really mature in KwaZulu-Natal. Yes, community health workers operate in other provinces as well, to different degrees. The challenges really relate in incorporating community health workers and creating into the healthcare system proper, and creating a career path for them. So the most recent issues relate to salaries and formal, recognizing it as formal employment. So there's negotiations underway, but it is something that requires a political will and push to actually incorporate community health workers formally into the healthcare system.
Great, thanks. Dr.
Mr. Magula, can I ask a question, Louise?
Yes, yes.
Thanks so much. That was a wonderful talk. I really enjoyed the breadth and the depth of what you were discussing, and especially about the social interactions of the healthcare system on disease and treatment. I was curious, I had two questions about COVID. One, you mentioned that it is a little less of a public health priority at this point, which is what we're seeing in the United States, despite the fact that in the US, there's still 1,600 deaths a week, which is, almost about twice as many deaths as we have from traffic motor vehicle accidents. So my first question is that happening in South Africa? Is it less of a priority for the public health agenda? And two, you mentioned a lot about the acute kind of burden of COVID on the healthcare system. We're starting to also see a large burden of long COVID that's become very resistant to treatment and difficult to sometimes diagnose. I wonder what your experience is with that.
Yeah, so yes, I think we have the same problem. And my sense is that probably politicians have decided that, you know what, let's get on with other business. And I think the slide that I showed you actually tells a very sad story. The slide that I showed you on the data across the country, that data comes from our National Institute of Communicable Disease. Throughout the pandemic, every single day there was a report that showed you how many people were confirmed with, how many people were admitted, how many people died. So that what I showed was just a superficial layer of it. We got that data. On the 31st of December, 2022, which is the slide that I showed you, that was the last time the data was collected. So since then, there isn't, and whether it's an issue of, obviously, they needed to ring fence resources to be able to do that. So I think what it means to me is that resources have been moved elsewhere. And we're still running a clinical trial. The recovery trial is still ongoing. I'm working in a facility that was repurposed for COVID-19. And so we actually have to search through the notification system to find patients that have been notified. So and people are not testing. So we have a lot of people that are presenting with respiratory symptoms that are not even tested for COVID-19. It's almost, to me, the sense I have is that we, it's like heads are being dug into the sand.
Yeah.
And we're seeing it, long COVID, it's just our patients are presenting with many infections, and they're presenting with cancer that's not diagnosed. My sense during the pandemic was that the patients that were coming out, it was a picture that I can create, is that I got a sense that these are people that were living with HIV that were supposed to go out and get tested, but never got tested, living in denial, but the virus, just like fire, made them to come out. That was my sense, because we're seeing patients, with CD4 counts in the boots. And now the two patients that I showed you today are patients that had never seen COVID-19, but had been vaccinated. And my sense of that is that we still have a large population that never got infected, that will probably be getting infected and die silently because people are no longer tested.
Thanks. Yeah.
And it's not just people coming forward, it's the clinicians not doing what needs to be done.
A question came in from your colleague, Dr. Mark Seidner, and he's wondering if he's thanking you for your talk and wondering about if you can comment on the potential opportunities of the national insurance program that's being proposed in South Africa. And then his second question is if you can give all of us academics on the call, and there are others on the call too, as well as academics, how to be good partners in trying to create policy change and political change.
So I know Mark very well. You would have seen him in the picture that I showed up there. And so the national health insurance, if I had time, I would have included it as one of the lights at the end of the tunnel. And there's lots of concerns around it because there's a lot of mistrust, because this is something that is coming from government and coming, to redirect or redo how the health system works. And because there's so much mistrust in government, there are some pessimistic views around it. But from a theoretical perspective, this is something that is meant to bring the public and the private sector together so that it kind of gets rid of this access that depends on whether you have or you have not. How this is going to play out, I think the jury is out, and we will support. We will actually support government to get this come right, hoping that they will remember when the pandemic started that they called academics together and other experts to get guidance. Now, in terms of how we get the politicians and so I actually have a story for this, because just last week I got invited by the Department of Economic Development, Tourism, and Environmental Affairs to give a talk to senior women leaders in that particular department. And one of the pieces that I take from that discussion as a response to Mark is that I shared with them the idea of how them as the Department of Economic Development, we can actually work together to, because what is missing in the country is that we have this need, which is real, to open opportunities
Oh, it looks like Professor is frozen. Let's hold a minute and see if we can get her back. Just when we were getting our final words of advice. I'm wondering if we should, what should we do? Ah, okay. Well, unfortunately, Professor Magula's internet connection looks like it dropped. But I think maybe what we should do, because we just had a few moments left anyway, is to wrap up. Oh, you're back. Oh, great. I was just wondering if we should wrap up or if we would find you back. Because
Okay, all
just
right.
have a few, we know we have a few minutes, so I'd love to hear you. You were telling us the story about speaking with
Yes,
women.
yes, yes. Yeah, so out of that conversation, I've actually been asked to write a proposal on how we do a public-private partnership, which I think is a direct answer to Mark's question. So after this, I'm going to be putting together a proposal that's going to go to the Department of Economic Development to share how we actually, as the public sector, can work with the private sector to establish private medical schools that will benefit the country. Because right now, we're actually losing brains outside of the country because we do not have space for those that have. And so, yeah, so that in a way is one way that we can work with politicians as academics to find solutions for the country that will make everyone to feel at home, and those solutions are going to grow the country and are going to find solutions for the health problems or burdens in disease that we have.
Thank you so much for that. Dr. Radican, did you have any final questions?
No, thanks. Thanks so much.
Yeah, thank you so much for this very inspiring talk. And really, I've learned so much. I really appreciate your time. We're really grateful for you speaking with us. So thank you very much.
Thank you. Thank you for inviting me. Thank you. I appreciate it. Bye-bye.